So if I could introduce my colleagues here, and then you might like to say a bit about yourselves. Mm-hmm. And I'm not sure if you've got any short statements you want to make, but it doesn't matter if you haven't. So if I could just say, I'm Julia Cumberledge. I was invited by the Secretary of State to chair this review with its 3 different aspects. On my left is Sir Cyril Chandler, and he is the Vice Chairman of the panel. And on my right is Simon Whale, who is the 3rd member of our panel. Next to Simon is Valerie Brass, Dr. Brass, who is the Secretary to the review. And on Sir Cyril's left is Dr. Sonia MacLeod, who is our Principal Researcher. So that's us. I understand that you've completed the COI, that we asked you the statement on any issues you've got in terms of of having any sort of connection with other organisations that might influence your views, and I think you don't have. I think the statement's been brought forward. And also you've sent us evidence, and we're very grateful for that. So if you'd like to start by introducing yourselves.
I'm Heather Angus-Leppan. I'm a neurologist and epilepsy lead at the Royal Free Hospital. So my interest is in general neurology, but particularly epilepsy and migraine. And I'm here as the representative of the Association of British Neurologists on the Epilepsy Advisory Group.
Right, thank you very much. Yes.
I'm David Baldwin. I'm a psychiatrist, Professor of Psychiatry at the University of Southampton, and I'm here in my capacity as Chair of the Psychopharmacology Committee of the Royal College of Psychiatrists.
Right, well thank you very much indeed. Do you want to make any statements or anything, or should we just start with our questions?
Why don't you start with questions and then we can...
Okay.
Yes.
So we've heard, because we've been right around the country talking to a lot of patient groups, and in this case certainly those that are being connected with valproate, and we know that they feel that on occasions they've been misled by clinicians as to the risks associated with valproate. And we understand the practices related to informed consent, which is an issue that's come up time and time again. But they have changed since the 1970s at that time. But I just wonder if you could be kind enough to outline your current practice and whether you feel the best practice provided actually gives enough adequate information for patients to understand the consequences of taking this particular drug.
That's obviously a central issue. I think that there is evidence from surveys that despite quite a lot of publicity until recently, a lot of women didn't know about the risks of valproate. Epilepsy Action and surveys in other countries as well have suggested that. So it is something that needs to be addressed. For people who are going to epilepsy clinics, this is now, I think, very well covered. The risks of valproate are discussed, as well as the potential problems of alternatives, and I think that's something that needs to be emphasised as well. That sometimes valproate is the only medicine that will control a person's epilepsy. So it's quite a complex equation. If there was an alternative that was as good as valproate, then we would always be able to use that instead, but it's not always the case. So people are facing sometimes very difficult decisions, having to weigh up a number of different factors. So I think that for those who are in a clinic, there is usually a good opportunity to discuss all of that. The concerns we have are really in terms of making sure that we have enough time and resources to make that discussion meaningful for the individual. It's an extremely individual decision-making process, and simply sort of giving a lot of information without discussion is not adequate. So we think more resources to do that adequately. And our other great concern is the people who are under the radar, who have been on, say, valproate for a long time, who are probably their symptoms are very well controlled, so they may not have contact with a specialist clinic. They may not even see their general practitioner very often, and we need to identify those people and make sure they're given the information, because they're particularly vulnerable to not having the information. Another group that obviously needs a special time and attention and overlaps with David's area are people with intellectual disability, where often they won't be able to make a decision themselves, and that will have to be done in terms of best interest practice, which needs time and needs expertise.
So when you talk about the clinic, this is a clinic that is a specialist clinic in a hospital?
Yes.
And
You're sometimes in a community, but usually in a hospital. So where someone would see either a specialist nurse or a specialist doctor who has expertise in epilepsy, in my case, or in other related areas.
So there is quite a danger that the GPs who are prescribing something like Epilim to control the problem that these women are suffering, they could easily just continue with the prescription. The woman continues to take the Epilim, and no question is put about the pregnancy and the result of pregnancy.
I think that has definitely been a problem in the past. Because of the alerts that are now placed on prescribing, that's less of a problem, but it still is potentially an issue, and it's difficult. We don't really have a clear idea of how, who is not getting the information. It's quite difficult to measure that.
Can you say what proportion of the epilepsy population who might be taking valproate are not actually being seen regularly by a neurologist? They're stable, their condition is stable, as you say, that they could be their follow-up goes through a GP. Do you have any idea how that proportion changes between those being seen regularly by a neurologist as opposed to those who go to a GP for their follow-up?
It's difficult to give you. I can't give you precise figures. However, if I just give you some of the things we know about. First of all, people with epilepsy who are taking valproate are likely to be part of the 1/4 of people with generalized epilepsy. And of those, most will have had. It's unusual for general practitioners to commence prescribing of an epilepsy medication. So that's going to be extremely uncommon now. So it will be people who may have been on it for a very long time, started a long time ago, before there was this awareness. It's going to be a small percentage probably, but we don't know the exact figures.
So how do you discuss with the patients about alternatives?
Yes.
And alternatives that they can take when pregnant that will not have disastrous consequences?
Well, I think we discuss the whole range of those issues that you've highlighted. We discuss the alternatives. We discuss the risks and benefits of alternatives, because some of the alternatives also have a risk of teratogenicity, and we also discuss the risk of not being on any medication at all, in terms of the small risk of having a very major seizure. Occasionally, that people can sometimes die during a seizure, and what the consequences could also be for their child if they had a major seizure. So we try and cover all of those possibilities as relevant for the person, because obviously that will depend on whether they want to have children, when they're planning to have children, all those sort of factors.
So patients have told us in the past that they haven't been made aware of the risks. And in fact, we've heard from some patients when we've been around the country talking to them, listening, who've said, I would have preferred to take the risk of having a seizure.
Yes.
And clearly now you're pretty convinced that women are actually told the risks and are made able to make the choices, which might not agree entirely with your medical expertise, but you would respect those choices.
Oh, absolutely. That is at the heart of the whole process. It's something that we have really championed, because we do think that we need to make sure we're not imposing our own view, our own worldview on people, allowing them as much as possible to be given the information to make informed choices, because there isn't one size that fits all, and people will. You mentioned that I have patients who have really severe epilepsy who have decided, as you've said, that they would rather take the risk of having severe seizures, perhaps, and be on a less efficacious medication than have the risks of teratogenicity. So, and others who say exactly the opposite, that they want to put their safety as the number one concern, and that they will take the risk of teratogenicity. So there are a whole range of different views.
So, do you in any way, I don't want to use the word train, but inform GPs about the approach that you think should be taken?
We do. Whenever we write a letter, we try and summarise the discussion that we have, and we've been involved in publications and discussing all of these issues, which GPs have access to. So, but in each letter we try and summarise that so that it's something that is also hopefully educational for other discussions they may have.
All right. Thanks very much indeed. So,
yes, Professor Baldwin, can I just ask you, I mean, obviously some of these considerations, all of these considerations apply in the case of patients with bipolar disorder, but you're dealing with a very different cohort of people, so it'd be interesting to get your reflection on that.
Thank you. Yes, that's right. It's a very different area of medical practice, and the balance of risk and benefit obviously differs from one subject area to another. We know that about 24% of women under the age of 50 who are receiving inpatient or outpatient psychiatric care are exposed to valproate-containing medicines. And a survey from the college, the Prescribing Observatory in Mental Health, showed that there was evidence that those women had been warned of risks in only half of the cases.
Sorry to interrupt, but do you know, what are the absolute numbers? 24% equals how many women?
In the survey that was published, it was across 55 mental health trusts. It's probably a few thousand if it was across 55 mental health trusts. I can get that information to you by sending the publication. But the point I was to make really was that that's in the case of women. Valproate's mainly used in bipolar disorder in psychiatry, but it's also used in other areas as well, and I suspect those figures are similar for the other areas such as schizoaffective disorder or schizophrenia. And when I became aware of the concerns relating to valproate and was in a position of being able to do something about it within the Psychopharmacology Committee, it struck me that the first step was really to review the evidence for where valproate is used and to look at all the possible alternatives. So obviously you start off with acute mania, the treatment of women with acute manic episodes, and then prophylaxis, the long-term treatment and prevention of new episodes of illness, and so on, which the committee did. And in summary, there are always alternatives to valproate that have similar effectiveness and roughly similar tolerability.
So that's a big difference in psychiatry as opposed to...
Yes, completely. Yes, it's a different area of practice. And this is what then led to the writing of our guidance. I don't know if you've been, because we wanted to summarise the evidence and then remind people of the alternatives and then give guidance on how to change from valproate-containing medicines to other medicines. And obviously we had to think about essentially kind of 2-by-2 table where you have the woman who is currently psychiatrically well or psychiatrically unwell, and then is pregnant or not pregnant, and you have to provide guidance on each of those 4 areas. But this guidance came out in just before Christmas and has been circulated to all members of the college. It was also contributed to by members from the British Association of Psychopharmacology, and it's been distributed to all their members as well. So the guidance has been distributed to all psychiatrists in the UK and another 900 people on top of that. And the college is trying to have a series of awareness-raising further publications through. We have something called Insight magazine, which is very well read by the psychiatrists. We'll be having an article in that and discussing it at our international congress and our divisional meetings. And the to include questions about valproate and the next generation will be keenly aware of potential hazards.
But how do you make sure that the guidance of this importance is adhered to by those in practice? And if it's not your role to do it, which it may not be, whose role is it?
Yes, well, I mean, when the NHRA statements were published, my own trust almost immediately was able to produce a list of patients. It was all anonymised, but with NHS numbers that were sent to the individual psychiatrists within that trust, saying these women under the age of 50 may well currently be taking sodium valproate, and we urge an urgent review of these women. And I know that system worked in our local trust, and I think that's probably what you have to do. You have to devolve it down to not the lowest level, but the most immediate level to where the consultants are working.
Has that happened in other trusts, as far as you're aware?
As far as I'm aware, it has. I don't know whether it's happened in all trusts, but I know other colleagues where a similar approach has been used.
So it's the employer who should...
Yes, I think so, and I think it would be a very careful liaison between trusts, medicines management committees, and the pharmacies, including the community pharmacists. And,
can I ask you, in the appraisal and revalidation process, your role, college, the colleges have a relationship with the General Medical Council to authenticate.
Yes.
Could you explain what that is and how the College of Psychiatrists might take the advice you've given and check it through the appraisal process?
Well, I mean, the appraisal process is obviously based to a certain degree on the continuous professional development needs of individual clinicians, together with mandatory training and various other educational activities. And at the moment, the college doesn't have any input into that. So that would have to be a new system to be developed.
It does set the standards, which the GMC relies on you to determine what those standards are.
Yes.
And compliance with good practice advice and keeping up to date, I assume, is part of that standard.
Yes.
And if there was evidence in the appraisal process of somebody not doing that, I imagine that would be then the person appointed in your trust as the person who validates on behalf of the GMC would be informed of that, presumably.
Yes.
I don't want to put words into your mouth.
Well, no, but it could be made a requirement, couldn't it, that as part of the annual appraisal process, that the clinician provides evidence that they have read recent documents relating to the safety of medicines in their particular area.
Yes. Now, is it?
No.
And would that be a good idea?
Personally, I think it would be a
So
good idea.
how can you make that happen?
Well, as chair of the Psychopharmacology Committee, I suppose all I can do is have discussions with the college council
Yes.
and the registrar and the president.
Yes.
I imagine, having had strong support from the registrar and the president for the development of this document, that they would be minded to agree. But obviously that's a discussion I would need to have.
Right.
Presumably the other group would be looking then at those who deal with, like the CQC, and the provider unit itself, to say that if you're looking at the provision of
Yes.
psychiatric services,
Yes.
you would expect to have seen evidence that this is being followed.
Yes,
But
that's
again,
right.
it's making that connection and knowing whether that's
Yes.
going to happen.
Yes, that's a very good idea.
Can I just go back to the 24% figure you mentioned earlier?
So
half,
can you-
the 24% of,
Yes,
of
yes.
women of childbearing age. So half of those were not aware.
Well, there's no documented evidence that they
Right.
were warned, and that's a slightly different
Yeah.
matter.
Okay.
But you have to assume that if it's not documented, then
Didn't
it didn't
happen.
happen. You have to assume that.
So my question is whether, since the introduction of the pregnancy prevention program,
Yes.
you think or you know that statistic has improved.
I don't know whether that's the case. The prescribing observatory on mental health is led by Professor Thomas Barnes. He's a member of the Psychopharmacology Committee. He has talked about how we could conduct another audit of the 55 trusts. I feel sure the college would be very keen to do that.
May I make a suggestion? The risk acknowledgement form, which all of us have to fill out if we're prescribing valproate, could be made an online form, which would allow us to gather information about the outcome of these women too in an anonymised way, and to see, firstly, to check that to look at the rate of information, correlate that with the number of prescriptions to females, and see how those people are doing as well. So we gather information about their safety as well, which is not being done at the moment. We're missing a golden opportunity.
There is a registry. There is a registry, isn't there, in Ireland?
Yes, but that is only 25% of all people.
I know it is, but it's likely the women would give permission to go on the registry, which you have to seek through GDPR.
Yes.
But would it, logically from what you just said, that could then link to such a registry?
That could as well. Yeah, that could link in, and if you had those forms online, then you would you could do that. We've got the technology to do that in a very clever way and gather the information.
Why hasn't what you're suggesting, which sounds very sensible, happened already?
Because it costs money. But
at the moment, we're writing
it.
How many are on the PPP?
We have a piece of paper which we give a copy to the patient. We give a copy to the GP. A copy is meant to go in the notes. You can imagine that the capacity for one of those forms to be lost, not to get in the right place, is immense. And then to try and gather back the information from each person's notes, it's cumbersome. So I really think we should do this. I've made that suggestion.
Why was the PPP made as a paper system when there's clear evidence, certainly international evidence, that you can run similar pregnancy prevention programs as online systems?
I think it would be a good idea to make it that way and to take a leaf out of other countries who do this a lot better than us, such as Scandinavia.
The paper-based system wouldn't really work in psychiatry because half of the trusts use exclusively electronic medical records. So it has to be online.
Can I just ask Professor Gordon about off-label prescribing?
Yes.
So in the case of some psychiatric disorders, valproate is used off-label.
Yes.
Can you explain why and how that works, and whether you've got any concerns about that?
Yes. So off-label use would be in patients with schizophrenia or schizoaffective disorder, which is very similar to bipolar disorder, recurrent depression, and in people with various forms of personality disorder, I suppose. The college has produced guidance on off-label prescribing, which came out in December 2017, and it starts off with, I think, 10 key points for practice. And for a start, becoming very aware with all the potential benefits and potential risks of the proposed intervention, and weighing up in the balance against other forms of treatment, and then talking about discussing it with a colleague if needs be, making sure you've had a full discussion with the patient, and if needs be with a relative, and so on. And I wrote it, and we know that that's been quite widely adopted in trusts across the UK. That guidance, as I say, came out in December 2017. It probably will need to be looked at again towards the end of this year. Most college documents, we look at them after 2 years, but I don't imagine that it would change. It's about principles of practice, but we'll obviously have an open mind about that.
So when evaporate is when it's used off label, and if the woman then goes on to have a child, which is affected by evaporate spectrum disorder, where does the responsibility lie in that situation?
Well, I suppose it depends on the degree of the conversation that the clinician had with the patient at the start of pregnancy or even prior to pregnancy. And you need to make sure that the clinician follows the body of opinion regarding what constitutes good practice. And that's why I was concerned a year and a half ago to make sure that there was very clear guidance as to what constitutes good practice when considering the prescription of medicine outside the terms of its product license. The college initially produced its guidance in 2007 on this, and we revised it in 2017. I mean, we looked at it periodically to make sure that it was still okay, but we revised it in 2017 because the GMC guidance relating to this aspect of medical practice, the wording of that had changed, and we wanted to make sure that our wording accorded with that in the GMC statement.
Because in fact, when you talk about sodium valproate not needing to be the first line of treatment, some of the things you're suggesting would be off-label prescribing in certain psychiatric conditions, if I read the physician statement right.
I mean, where it's mainly used is in acute treatment of manic episodes, and there are always other treatments which are possible with
antipsychotics. But those two would be off-label?
Yes. And that's the case usually, isn't it, with a pregnant
So when it comes to something like adverse event reporting, does that sort of fall out with the off-label usage?
I'm sorry, actually, an antipsychotic would not be off-label for an acute manic episode, because in the BNF, some of the antipsychotics are described as anti-manic drugs, so it's not off-label.
So I may have read it wrong, but I thought you were saying that for some of these where you're suggesting not using sodium valproate, the use of the drug in those circumstances within a range might be off-label.
It would be off-label in patients with schizophrenia and in recurrent unipolar depression. But in mania, bipolar disorder, it is witin label.
Okay, so we have a situation now where we are suggesting that for some areas of concern in psychiatry, we will be using them off-label. Adverse event reporting.
Yes.
When you're using an off-label drug.
Yes.
Do the same sort of rules apply, or is it no one actually taking any notice of that because, of course, it was never meant to be prescribed for it in the first place?
Well, our guidance to our members is very clear that in that situation where you are prescribing medicine outside of the terms of its license, particular vigilance is needed. and adverse events should be sought and documented and reported as necessary.
Okay, and do you know that that's what happens?
No.
Do you know, I mean, sorry, I keep asking about numbers. Do you know how many women are receiving valproate for off-label use? Or how many patients in total?
I wouldn't want to guess that. I could very easily provide that information on the basis of the POM-8 survey. As I said, it was 24% of women across 55 trusts, of women under the age of 50. I could get the number for you, and then we could look at that as a proportion of all trusts across the UK. It'd be easy to do that, but I'm conscious that I'm being recorded. I don't want to give the wrong number.
That would give it, no, that's fine.
Lovely if we could have a follow-up afterwards.
Yeah.
But that would provide us with both licensed and off-label use.
Yes, that would. Yes, it would.
Yeah, that would be very helpful.
Yes.
What I was just going to say is, in terms of sort of, I'm thinking also in terms of women who are epileptic, if valproate, for example, is being used outside the terms of its label, so the terms of its label are quite clear, there must be a PPP in place. And if people
Sorry, I didn't hear the last bit.
In terms of using valproate outside the terms of its label,
Yes.
which says there must be a PPP in place,
Yes.
if women choose not to use contraception and are still on valproate, and that is a choice that is taken,
Yes.
what are the responsibilities of a doctor in terms of follow-up, in terms of sort of, presumably that then becomes an off-label prescription, if you are aware of that?
We, at the moment, that obviously needs to be incredibly carefully documented. The PPP form, what our practice would be to annotate that in a lot of detail, and then also in the notes as well. And we've made the point that there are times when the PPP is not appropriate, for example, because of someone's religious beliefs, which preclude them from using certain forms of contraception, some major health-related problem with using the forms of contraception suggested, or if they have significant intellectual disability to the point where they can't make informed choice, then they would also not be able to make an informed choice about having a sexual relationship. So the only way in which they could become pregnant was if they were abused. So their family and their carers may think that it's not a fair burden to place them on regular injections, for example. So we're annotating that form very carefully, but we have made a plea that the form be given, that there are exceptional circumstances where it's not appropriate, and that needs to be taken into account. I think in medicine, it's important not to be too rigid and too dogmatic, because there are going to be exceptions, certainly for epilepsy. And I think maybe even in psychiatry, there may be times, although you go through all of the standard treatments, someone is still resistant or has a problem, that you may end up thinking valproate is the right choice for them if they are agreeable and they understand, or they may decide that that's the best choice for them. So I think we have to have some flexibility.
We live in an age of increasing specialisation.
Yes.
Compared with when I qualified, it was a long time ago. We think there are maybe as many as 20,000 people who've been affected by valproate in England. And the suggestion has been made that to meet their needs, both medical and social, that it would be useful if there were a limited number of centres which acted as hubs in different parts of the country, where they could go to get very special expertise and could also help around their regions in making sure services are adequate. For instance, in clinical genetics, it's been pointed out that this is a very special sort of genetics that is interested in valproate and genetics. The same thing might apply to neurologists, it seems to me. There are some neurologists who specialise in epilepsy and so forth. Anyhow, the point is, do you think, from your point of view and your point of view, that such centres would be useful?
If there are enough and if they have enough resources, then
Well,
yes.
you did mention, I made a note, you want more resources.
Yes,
This
I'm
might
sure
be a
I'm
way
not the
of
first
providing
person to
them.
have asked for that, but I think we also have to obviously take into account the practicality that a lot of people with epilepsy can't drive, so getting to a centre that's not close to them is particularly burdensome. And also they may have developed a wonderful relationship with a general neurologist who's looked after their epilepsy for a long time, and they may not really want to go to a super specialist.
That's why I said it's a hub, so that
Yes.
if you were in the hub, or wherever that was, you would not only, you'd have a register, but you'd have a relationship, not only with the patient, but
Yes.
with the neurologist.
Yes. Yeah,
There is a paediatrician I used to have a relationship with, general paediatricians around the southeast,
And-
and children with kidney disease.
Yes, that could work very well. Yes.
Yes, I think it could work well as too, actually, if it were done on a regional basis with close liaison between neurology and psychiatry and the other disciplines. I suppose we know quite a lot about what happens to babies that have been affected, but undoubtedly more could be understood about their development and course into adult life. So I think it would be a useful clinical service, but also an opportunity to actually characterise the problems that people have in more detail, and that should lead to greater understanding of the problem.
Can I ask, giving the right contraceptive advice is obviously so terribly important for both your fields when you're talking about prescribing valproate. Are neurologists and psychiatrists comfortable doing that?
No. We can't give specialist contraceptive advice, and we have to obviously liaise with the general practitioner or with sometimes with a specialist gynecologist, and that's not within our expertise. We can only give very sort of general signposting about that.
So they come to you, and valproate is the desired choice in terms
Yes.
of treating their epilepsy. You realise that there's a problem because this is a woman of childbearing age.
Mm-hmm.
So the first thing you do is then refer them somewhere else for their contraception?
Sometimes it's already quite clear. For example, if someone had an intrauterine device which they were happy with, then that's quite straightforward.
On the basis they've told you that?
Yes. So we have to make inquiries. We have to have an understanding of what their contraception is, and then if it's not within that guidance, then we have to liaise if they need more specialised advice about it.
So that'd be a specialist gynae or GP?
Or it depends. I mean, some GPs are very skillful at that, and that's well within their
some are clearly not, as they told
Yes.
us last time. They would
So I think
refer back to the neurologist.
Yes.
So. And the psychiatry.
Well, I think it's timely in a way. In our guidance, we talk about an increased role for the perinatal psychiatry teams, and of course, recently announced an expansion in perinatal psychiatry services. And I know many psychiatrists who are currently working in the area of general adult psychiatry are actually going to be moved into perinatal psychiatry. So I think there's an opportunity for raising awareness, increasing people's confidence in discussing contraceptive matters. I mean, perinatal psychiatry now tends to deal with women in the late stages of pregnancy and the early weeks after delivery, but actually there is an opportunity for it to go back in time. Yeah.
Can I ask you a much more general question? We're obviously looking at these three different areas, but what has united them? Of course, they're women's problems, and we understand that, but secondly, they are areas where the patients themselves have been so concerned that so little has been done to help them with these different conditions. And with valproate, we've got some patient groups who are terribly well informed, and I'm sure they come across your desk as they do ours. They've done a lot of research, but actually it has been Parliament in the end, it has been the Secretary of State who has brought this to the attention of the population generally, and certainly to the medical profession and others. Can you think of any ways that actually we should listen much more carefully to what people are saying? And I'm talking about patients who've been affected in these areas or indeed in other areas. How do we bring that to fruition in terms that actually action takes place? I mean, this review was stimulated by the patient groups. That shouldn't really happen. One should have mechanisms that it brings this to the fore without having to involve people putting in so much effort, so much of their lives, in order to ensure that attention is given.
In terms of making sure that healthcare professionals are doing a better job of this, I think that there's a need for not only sticks, because there are sticks, there are punishments if you don't do the right thing, but also a change in the focus and the way we're thinking of patients. And it has happened a lot over the last decades. Even when I started medicine, we thought of that you gave information to people, you told them what to do, and that was kind of thought to be the way that you treated patients. That was the model. And it has reversed, and it is all about patient empowerment, and that is to make that more than just an empty phrase. Then I think we need that has to start with education of doctors and nurses and everyone who's involved in looking after patients, and that is about respecting their rights for full information, which is what recent rulings have stressed. And which again is not just, it's going away from the paternalistic attitude that you just tell people what you think they should know and you make a decision you think is in their best interests. And I think a lot of us are aware of that and doing our best. It needs to be continuously promoted from when people are starting to do nursing and medicine.
Because collectively they can make an impact, and they have through the parliamentary system.
Yes.
And other methods. But as individual patients, it is quite difficult to feel empowered.
Yes. I think that needs a lot of ongoing work. But I think we also have to remember the patients you're not hearing from, who want to stay on valproate and who want their rights respected as well, not just the more vocal members. It's very important.
Well, thank you.
Can I just ask about issues around consent? As Baroness Cumberland mentioned at the beginning, we've heard from many people about how they didn't feel that they were properly informed and couldn't make the kind of choice that you would want them to be able to make based on what you just said. I guess in psychiatry there's a cohort of people who it's quite difficult to provide informed consent to, or for them to provide informed consent to you. How do you tackle that situation, and is it a significant problem?
Well, in relation to valproate, I suppose the area that might cause greatest concern is in women with acute manic episodes who may well have significantly impaired insight. In the other areas, I think there's always time to prescribe alternatives and to have lengthy discussions if you are thinking about valproate. But in acute mania, I personally don't see the need for valproate to be prescribed, and this is what we say in our guidance, because there are alternatives that are safer in pregnancy. The antipsychotic drugs are. Now, of course, you may still be prescribing at a time when a woman is not able to provide full consent, but at least you're using a medicine that is potentially less hazardous. So I hope that the guidance is clear, that in that situation it makes sense to use a sort of tried and tested and safer medicine. I can't see a reason for someone to prescribe sodium valproate in a lady experiencing an acute manic episode.
Would you prescribe valproate in a man having an acute episode?
Yes, you could. Yes, you could.
But would you?
Personally, I don't. I very rarely prescribe valproate because I don't find it a useful drug. We know that there are men who are prescribed valproate.
I guess what I'm trying to get at is it's not that women with acute mania are being offered a slightly less efficacious drug because of the risk they'll get pregnant. It is that it isn't a drug that you would necessarily recommend.
I mean, I think in obviously in men the balance of risk and benefit is different to that in women. But I mean, usually in acute mania, you're wanting to get the patient settled very quickly.
Yes.
And valproate is not as good
Okay.
as the antipsychotic drugs in doing that. And that's, particularly important in a robust young man, actually, that you get them settled
Yes,
quickly.
I can see that. Yeah, okay.
Can I ask, just about looking back and about looking forward, valproate's had about 45-year history. One of the things that is really at the heart of the patient concerns is who knew what when. The manufacturers are very clear that they have always known about its heterogeneity, and that's been put out in the patient data sheet, of the data sheets that went to doctors, not in the patient information. I mean, you're both here as sort of representatives of your associations or colleges. To what extent should doctors have been much more upfront, knowing what they should have read in the data sheet, but not actually saying to patients, went back a number of years, this was the risk that you're taking?
I think that clearly we have a duty to inform about all of the risks of any medication we try, and about the benefits as well of the medication, and all of the. So I think that most of us have been, or certainly within specialist care, have been informing about teratogenicity of valproate for a long time.
Way back, at the point at which you would
Well,
receive the information.
Way back, I wasn't actually working, but
it's that responsibility.
Yes, I think people have been trying for some time. However, I think that the degree of teratogenicity has become more highlighted recently, definitely, and it's put in more stark terms now, definitely. But we in epilepsy care, you have a number of other factors, like the teratogenicity of other medications,
For sure.
the benefits of other medications in terms of seizure control versus valproate. So it is a complex equation.
I know it is. I suppose the issue for me is that there was information in those data sheets, and there were studies happening alongside that, and the extent to which the colleges are taking cognizance of those studies, what they're saying is raising concerns, and should they be saying to doctors, look, you've got these patients coming to you, you should be saying something to them, and I'm not sure that was what was happening.
I was looking back into the history a couple of weeks ago, actually, because I've been preparing some talks, and it struck me that the first case report was around about 1980.
A long time ago.
Yes, and the case series just a couple of years after that. And then I was thinking about, when does evidence become reliable? And I thought, well, certainly at the time of pharmacoepidemiological studies, where you can look at potential confounding factors. And then at the time of meta-analysis of those pharmacoepidemiological studies, which seem to be coming through around about the mid-1990s.
So
Yeah.
a lot of babies were born.
Yes. But you want a time when the evidence is, reliable and
The question is,
unequivocal.
did it happen soon enough?
Yes.
And I think that's a big question that remains as far as I'm
Indeed.
concerned unanswered.
But from that point onwards, then it's clear that people should be warning people.
Going forward, we have new generation of anti-epileptic drugs, something like Keppra. Are
Yes.
you convinced now that we could not have a repeat of the valproate story for a new drug like Keppra?
No, we can't be convinced of that at all. That's. I mean, there
Studies
is.
being done, the adverse event reports flowing.
I think we are doing it we've got pregnancy registries. We've got reporting, it's ad hoc. I think we should be doing it in a much more rigorous way than we are. We should be gathering information about all pregnancies, and some countries do that. I think we're doing it pretty sloppily, quite honestly.
So what would we need to do to make it better?
We need to have a registry that of all women who have epilepsy who become pregnant without and with medication, so that we're monitoring all of the registries. The UK is the best one. It has about a quarter of people who sign up to it.
And
some of the others
follows the baby. Only
yes.
until the baby's 3 months old.
So I think that we could, that should be incorporated, and I think from people I speak to, most women would be quite prepared to do that anonymously. It would be pleased to do it.
And how long should the follow-up be?
Well, we need to follow up for quite a few years, until at least the school age. At least until 5 or 6, when you,
Yeah, it's the long term.
Because it's often at school age that things really become apparent.
Yes.
Would they want to be anonymous? Most people I've spoken to in the registries I've been involved in are delighted to be on the registry, because they know then that the research is being done which would benefit them. So patient identifiable information may be useful to them. And so it is true that under the confidentiality rules, you've got to do it anonymously, but if you want patient identifiable information, you've got to ask the patient.
Yes.
But I would have thought they would probably say yes, wouldn't they?
Yeah, I think a lot of people would opt into being unanonymous, whatever the word is.
With proper,
identifiable, I think
with
that's what I'm
proper,
trying to say. Yes.
security.
Yes.
Who should run such a registry?
The government should be a centralised initiative funded by the government, so that it's really impartial.
It's not the same as who might run it, who funds it.
Yes. Well, I think you'd need to have a consortium of people, from different areas: neurology, psychiatry, epidemiology, pharmacology, who can make sure that the data is well analysed, and statisticians, of course, rare as hen's teeth.
In psychiatry, we have a monitoring system for the drug clozapine, an antipsychotic drug, and when the drug became available again, having been withdrawn, the requirement was that all patients exposed to clozapine would be part of a monitoring service. That was very important because you need to monitor the blood count every week initially, and then less frequently. And then generic drugs became available, but for those manufacturers to get a license, as it were, for their product, they also had to agree to offer this monitoring service. And patients with schizophrenia, who generally don't like being monitored and often quite worried about being monitored, actually seem to take part in this without difficulty. There are people who are kind of insight less and don't want to have treatment, but the concern isn't about being on a monitoring service, it's for other reasons usually. But the system has been running since 1992 for clozapine, and it works well.
But it's a fairly low level usage, isn't it?
Yes, and it probably should be used more actually. Clozapine should be used when people have not responded to 2 antipsychotic drugs, if possible. So it should be used more, but it's been running a long time, and so very large numbers of patients have actually gone through this process. It might be that if you look at the clozapine monitoring service, it provides some suggestions of how this could be done in another area.
Right, I'm going to draw this to a close, if that's all right with you, and I'm going to ask my colleagues if they've got any final questions they'd like to put to you, and likewise if you want to ask us anything in particular. So,
Thank you.
No.
Right. So,
Would you like us to send some more information that we think might be related, some facts and
Yes, please.
and things that are sort of related to what we've discussed? Yes. We said that to Donna?
We are great
Yeah.
hoovers.
Yes.
We like to
you like to stay up all night reading documents.
And I hope to send you a sort of a quick summary of what we're intending to do to raise awareness relating to this document as well.
Right. Well, thank you so
Thank you
much.
very much.
And
Thank
it's been a really interesting session, and I do want to thank you for coming. It's been really, really helpful.
Thank you very much.
Thank you very much.
Thank you.